Good afternoon. I'm Trina Sheets with the National Emergency Management Association, and I'd like to welcome you to our webinar, Early Warning, COVID-19 Detection in Wastewater Streams. And now it's my pleasure to introduce our moderator, Chuck Chadovitz, Vice President, Environmental Affairs and Sustainability with the U.S. Chamber of Commerce. Chuck, over to you.
Thanks so much, Trina, for your kind introduction and for including the Chamber. Pleased to be here with leaders from NEMA and AECOM to raise the potential use of innovation in advance of the very challenging public health and economic crisis that our nation is facing. As you know, the Chamber is the largest business trade association in the world, representing companies of all sizes and sectors, including members of a federation made up of more than 2,600 state and local chambers and member trade associations. As I like to say, the Chamber is at the intersection of where policy meets communities and companies. Building modern, resilient infrastructure and preparing before the next crisis, and I think this is critical at this time, has been long a priority for the Chamber and our members. We look for ways to reducing risks for our members so that they can go about the business of business and put Americans back to work. It's an honor to be here with Beverly and Paul, two experts who will outline the opportunity to establish a possible national program that will promote wastewater testing as an early warning or leading indicator for COVID-19. When so much of what we know is after the fact or lagging, getting ahead of our understanding of what is coming in this public health crisis could not be more critical. This is so important that the business community, that we're including this issue in our advocacy work as we move forward with a phase 4 stimulus package later this summer. With that, I'd like to turn it over to Beverly and Paul.
Thank you, Chuck. Good afternoon. Well, this concept of wastewater monitoring is a pretty interesting one, and the intersection between the concept and the science is somewhat explained here on this slide. What we know is that when a person becomes infected with the COVID SARS-CoV-2 virus, they begin to culture that virus in their gut. And after about a day of being infected, they begin to shed remnants of that virus in their stool. Now that, of course, ends up in the wastewater collection system for centralized treatment facilities. And what's interesting is that most of these infected individuals will not even really demonstrate the symptoms of infection for about another 2 weeks after they become infected. So from the point of time of infection, they begin to shed the virus. It shows up in the wastewater system about 2 weeks before they would ever seek medical assistance and support. And they continue to shed that virus through until the infection is either cured and that it is passed for probably about another 4 weeks. And so the really interesting thing is that this is true whether someone has mild symptoms or severe symptoms, as is shown here on the slide. And so even for asymptomatic patients, they would shed this virus at the same rate as somebody with severe demonstrated symptoms of SARS-CoV-2. So the true point here is that this is a leading indicator. If we monitor wastewater for remnants of the virus in the wastewater, we would have almost a 2-week lead time to understand the trends in the community of either an increase or a decrease in the prevalence of the presence of the virus. So what this can do for us, of course, is it can give us an early warning sign of any potential reemergence of the virus. This could be a reemergence during reopening strategies, or it could be a reemergence later in the autumn when we anticipate a reoccurrence of this virus and a prevalence of the virus as the temperatures in the weather drop. And so by monitoring the wastewater, we would have this early weather vane as to whether our reopening strategies are causing potential reemergence of the virus, or whether in fact things are staying quite steady and that the virus is not spreading. It would also give us time then to actually identify which locations in the community are seeing a reemergence of the virus. So by monitoring at wastewater treatment plants that are spread throughout multiple communities, it's almost possible to identify hotspots in a city, a state, or even across the United States. And that allows us, of course, to deploy valuable resources to where they are needed quickly to prepare in advance both facilities, hospitals, and of course, many other policy decisions like protecting the vulnerable and so forth. But this allows us also to augment and optimize the use of individual testing and tracking. It's not a replacement for those techniques, but it is something that allows us to get early deployment of test kits and medical equipment. It can help us to begin to send public warnings so that we can prevent the spread of the virus. And this allows, of course, the emergency response community to be better prepared. Now, this is not a new concept. Wastewater epidemiology has been around for decades, but it is a relatively new concept here in the United States. But elsewhere across the world, it has been employed and is increasingly becoming a baseline activity in many of the nations to monitor for SARS-CoV-2. And one very good example of that is the Netherlands, Finland, Germany, Italy, and the UK are all implementing nationwide programs. France and Australia have implemented pilot programs in their major metro areas. And this is something that has been used specifically for SARS-CoV-2. But in Israel, it was also used for other pandemics such as the polio virus. So these are some of the reported case studies around the world. There are multiple papers published now demonstrating this. Paul will speak in a moment to the condition that was occurred in Israel. But what we do know from specifically the nationwide monitoring programs in wastewater in the Netherlands is that the Netherlands was able to detect the presence of the remnants of the virus in the wastewater 3 weeks before the first reported health case was ever made aware to the local public health agencies. They have, of course, been monitoring and using wastewater epidemiology for about 2 decades. They used it to mitigate the original SARS pandemic in the mid-2000s, the MERS pandemic, and now they were ready and prepared for this SARS-CoV-2 pandemic most recently. In Italy, it was interesting that the Italian National Institute of Health reported that they had tracked remnants of the COVID virus in the waste in mid-December, but that the first reported case in Italy didn't occur until almost 40 days later. Now, they consider this to be a strategic tool in monitoring and early detection of SARS-CoV-2 moving forward. It's also been a technique used for other viruses.
You know, as Beverly said, this is not new. The science is not new. The testing is not new. In Israel, they have been doing this, what they called at that time, sewage surveillance, where they tested their wastewater out of trunk sewers once a week. And they put this in 1989. In 2013, they started to see an uptick in the trend of the polio virus in the wastewater. And as I said, this was the same test that we would use for COVID-19 or SARS-CoV-2. So what this did for them, it informed them that this was happening. They were able to actually track it back in the sewer system, back to the Bedouin population and whatnot. And so what they did was this informed the public policy makers, and they implemented a public vaccination program, which averted a larger scale outbreak. So, this is a very good example of how the early action that we're talking about here can actually work into real, life-saving public policy. So, looking at this, and right now we're in the middle of a pandemic. I think some people, you could look at the curves and they're bent way down, but someone had a great quote from Churchill, who said, this, as this curve was going down, and the quote is, this isn't the beginning of the end, it's the end of the beginning. So, what do we do as we move forward? Now, this study was done, it was a predictive model by Columbia, and you can take the numbers with a bit of a grain of salt. It's being peer reviewed, but the point here is that the predictive model showed that with early action, you can save lives, you can save people, you can reduce the number of cases. So, public health officials that we've spoken to has said every day that we can get is important to inform policy. So this shows what their model showed for 1 week. If we did the social distancing, 36,000 deaths could have been prevented, avoid 700,000 cases. In 2 weeks, excuse me, could have saved 54,000 lives, or averted 1 million cases. Now, as I said, those numbers, can be talked about, and they're being reviewed. But I just want to make the point of the importance of the early detection.
This is the type of concept then that we believe could be used from a very large scale, nationwide, down to state monitoring to identify hotspots across the nation, down to a state level and even within a state, but more than that, even into small local communities. Generally, wastewater treatment facilities serve populations as small as 100,000, as large as 1 million. And so we can find that in for instance, a center, a city center region, an urban area, we would have multiple suburban wastewater treatment facilities. And for those who are commuting in and out of the cities, it's possible to even identify if perhaps there's a hotspot in a suburban area, but not surrounding areas, that could be identified immediately, real time, not 2 weeks later when health cases are starting to emerge at the hospitals and emergency care centers. The really interesting thing about this tool is that it can go into small subdivisions. So even within a wastewater collection system, we can go back up into the sewage collection system and identify even points of interest. That could be, for instance, a nursing home. We would be able to have monitoring that would detect early the potential emergence of the virus in a nursing home, a prison, colleges, and so forth. And so this allows for quite localized point detection, or perhaps at a pump station from a large suburban area. And so this is the beauty of this type of concept. It's quite scalable, which gives us a lot of flexibility in monitoring from state to local level. And it can be quite readily and quickly implemented. The nice thing is that our wastewater systems are existing infrastructure. We have dedicated and capable and professional wastewater operators that already manage these complex systems. We have detailed models of the sewer systems, GIS mapping that can locate exactly the service areas. So this is existing infrastructure that could be leveraged quickly. And there are about 15,000 wastewater treatment plants across the nation. Just implementing it, for instance, at the largest 300 would cover over 70% of the population. So it's a straightforward procedure where we would collect split samples from the existing wastewater treatment plants. There are some specialized treatment techniques that one needs to test for this particular virus. But the good news is that those techniques are developed, are proven, that the protocols are being, are actually, it uses the established CDC protocols for the monitoring. And so there are some preparation steps that the protocols have been established for. And this could be done at local labs across the nation. It doesn't have to be shipped across the country. Many of the local labs have the right equipment. They have the ability then even to work with local universities on this to execute the analysis and partner with the local CDC and healthcare staff and local epidemiologists to be able to translate the data. The reporting is quite simple. It can be done effectively with trend graphs, easy to understand hotspot maps, and can be developed consistently using the same dashboards, not only at a city, state, but at a nationwide level.
So, you know, a question that we're asked a lot is, okay, in real terms, how can this be used and implemented? How can this be a useful tool for us? And one of the themes that we've been saying, you know, since the beginning of this is that, you know, this is the only leading indicator that we have. And if you look at the graphic that we have up here, you can see where wastewater monitoring fits in. You know, we'll get people tested, and that will be a lagging indicator. Self-reporting. Hospitals will provide data. We can, you know, we can do some proximity tracking too. But once again, this is the leading indicator that will help inform public policymakers, emergency managers to implement policies. And you know, what do we want to do with this data once we have it? And there's a few simple things that we know, and obvious things maybe. We want to contain the virus. So as Beverly mentioned, this can be localized into smaller areas, zip codes, neighborhoods. We want to limit the spread. We want to do things smart. We want to quarantine smart. We want to protect the most vulnerable. Beverly mentioned nursing homes. On a personal note, I unfortunately lost my mother in a nursing home to COVID-19. So it's a very real thing. I think we've all seen the news, and I believe the number is like 25% of all deaths were from the nursing homes. So we want to give them the early warning. We also want to avoid large-scale shutdowns. We don't want to shut down whole states. I think anybody wants to shut down whole states. So if we can, you know, pinpoint or localize where this hotspot is actually happening, we can take actions in those specific areas and not shut down the whole state. And this will also give us a tool that we can verify the actions that we're taking. Is what we're doing working? Do we stay the course? Are the trends going down? Can we loosen things up a bit more? Or are the trends going up, and do we have to go the opposite way? Do we have to tighten up a bit? So these are the types of things, you know, as I said before, we're in the middle of this pandemic. A good term that someone said to me was that it's like there's an active shooter out there, and we've got to protect ourselves. So this is a way, another tool in the toolbox that we can use to do that. So what do? As we said, you know, we can identify emerging hotspots at the sewage shed level, you know, the whole area that a wastewater treatment plant covers, community levels, and we can have focused and localized social distancing. Maybe people in a certain area where there seems to be an uptick, maybe we tell them, you know what, you got to put your mask on. You've got to, you know, stay. You know, maybe in those areas you say, you know what, if you're going into into work and you can work from home, it might be good to stay home and not go in. And another thing is the individual testing. You know, this can be targeted for these areas, and then smart quarantine for people only in those areas if possible. Contract tracing can be done more easily if you know where the infection is, where the uptick is. And then, you know, reopening strategy. You want confidence that when you're letting people gather, when you're opening up restaurants, businesses, schools, parks, beaches, that you can do it with some confidence that, well, right now the indication is that it's not spreading, so we can keep them open. And of course, and I have this bolded down here, the key is to avoid the large-scale shutdown, at the same time protect public health. That is where we want to get to. That's what this type of a technology can help us do. So, you know, Beverly touched on it, I touched on it, protecting the most vulnerable. This is very important. Nursing homes, you know, you got people with their elderly, compromised systems, immune systems. So an early warning could perhaps have these nursing homes limit or restrict visitors. I use the term lockdown, but I hate to say that. But and then provide the staff with the PPE, get all that going, get them trained, talk to them. Hospitals, alert them. You know, we could start seeing people coming in. Do we have treatment spaces available? Do we have the right ventilators at this hospital? Because this is where they're going to come. And you know, then we can also look at the standalone facilities. We can get down to a manhole outside of a certain facility, of a hospital, of a nursing home, to see if we're getting cases in there. Another big issue is the jails, prisons. People are in there, and you can test from the outside. And if you start seeing the uptick, you can, well, the prisons can, or the jails can, you know, do what they can to quarantine people. And of course, airports. We'll show you a case study that we're doing up in Bergen County, and we have a small airport. I think the population of the town is like 67, is right, you know, that's the living population. So they don't have a lot of cases now. But as people start to fly in, are they bringing in the virus with them? And monitoring outside of the airport can really help us see that, and once again inform some proactive measures. So I mentioned Bergen County. So Bergen County is in the northeast corner of New Jersey. It borders the Hudson River, New York. The area that is served by this client, by the BCUA, is 580,000 people. They have 2 wastewater treatment plants, 1 large, one small. They have 4 hospitals in this area, 9 pumping stations. They have a county jail, and they have 170 metering chambers. And I bring that up because these are all points that we can test at, and we can break the system up as we're going. Right now, we just finished the first phase of this, and Beverly will show you some of the results that we're getting. And that was done at this Little Ferry treatment plant. We were sampling 6 days per week out there. And so now we are entering into the second phase, where we're going to start going out into the system. So we're going to go outside of a hospital. We picked a few pumping stations in diverse areas, commercial, urban, residential. We're going to be outside of the county jail and that other smaller treatment plant. So what we're doing here is not only are we looking for the presence of COVID, but we're also establishing standard protocols for sampling, for testing, seeing some of the impacts of some of the things that the treatment plant is doing. Chlorination, does that help? Is it best to take the sample in the liquid stream or in the solid stream of the treatment plant? So these are all things that we are working through right now. And so this pilot, or this demonstration, will be going on for the coming months.
So one of the things that we've found to be very important is the manner in which the data is managed. The interesting thing that I think we're doing to improve the protocols is we're not just testing for the SARS-CoV-2 virus. The methodology that we're utilizing actually tests for an entire biological fingerprint in the wastewater. It tests for a range of viruses and a range of bacteria. Why do that? Well, it's something that occurred to us on multiple levels. There are two main reasons. Of course, the common flu is a coronavirus also, and so we felt that it's probably good to get some baseline data on all the different types of viruses and bacteria that we typically see in the wastewater, so that we can even get an early detection of an increase in the flu, for instance, as opposed to SARS-CoV-2. And that could be helpful, or in fact, being able to differentiate. The second reason that we were doing the entire sequencing is to track the strains of the virus. We know that this virus mutates. Does it mutate meaningfully? I'm not sure that we know yet. And so as vaccinations are developed, we'll be able to actually test the strains and monitor the actual quantities of the various strains in a community, whether it's the Wuhan strain, the Iranian strain, the Washington strain, or some other mutation thereof. So having that helps to give early warning indications even of other health-related illnesses. Another element that we thought was useful in this particular test case or demonstration here is to test for a range of chemicals. And again, why so? Well, oftentimes if one is feeling ill, folk will begin to self-medicate. We'll see perhaps a chemical trace of an increase in antidiarrheals in a wastewater, which is an indicator that there's something happening. And often that happens 1 or 2 days after even the contracting the coronavirus. And so tracking those chemicals is also a very good early indicator of things. And we will begin to see a decline in that RNA ahead of when health cases even come down. So this leading indicator can tell us that things are moving in the right direction, as well as tell us when things are moving in the wrong direction. There's also, it's important, we find, to manage the data that comes out of the lab and to standardize it. This is easily explained by things such as cities with large wet weather infiltration into the sewer system. Clearly, the concentration of the virus remnants can decline in a wet weather event. That doesn't mean that it's gone away. It simply means that it needs to be corrected for. The data has to be normalized. There are a multitude of environmental and other factors that we need to watch for and correct for when looking at the data that come from the qPCR monitoring and the sequencing. And I think we're going to find that particularly important in the temperatures increase over the summer. I think we're going to see greater decay in the sewer system. In fact, we're doing a research study to quantify that so that we can actually correct for the decay that occurs in a warm sewer system, rather than just assuming that it does not decay at a different rate than in the colder temperatures. So there's quite a bit of data normalization that needs to occur. When that occurs, then the quality of the data is much more meaningful and helpful, and that's a key here to decision makers such as yourselves. I think you need to know that the data is solid, that it's reliable, and that it's something that you can depend upon to make decisions. And so the presentation of that quality control data is important. The trend maps, the heat maps, that sort of information is what's most helpful to policymakers and decision makers as they speak with the local health officials. Some of the data here we can see in this particular instance. We've been tracking a number of different parameters, but the influent wastewater, the concentrations are relatively stable. And it just so happens that the number of cases is actually quite stable in Bergen County at the moment, still at around cumulative number of cases of in the 12,000 range. But that from day to day, we're seeing a steady number, and so the data is actually reflecting that. The not so good news is that we're not seeing an early indication of significant decline just yet, but some decline. And we're also looking at if there's a more meaningful parameter to monitor other than just the liquid, because we know this virus tends to accumulate in the solids, and so we also track that for information. Bottom line is that for a nationwide monitoring system, we see the need to set the standards and the protocols so that it's a meaningful sharing of data between cities and states. And this allows us to correlate and talk to one another in a meaningful fashion as to the rise and fall of the occurrence of the virus. And how could that be used? We think it's possible, and of course this is an area that we probably are not the right people to inform on this, but one mechanism, of course, is to use and report this QA/QC data up through the emergency operations centers. And if it's standardized, it's possible then for meaningful trends to be graphed and heat maps to be provided and developed and information to be shared in a consistent manner between cities and states and even nations. So this is one way in which that data can be brought to a central location. Health officials, policymakers can debate the next steps based upon quality data.
Yeah, I'll take this, Bev. You know, another question that, of course, is asked is funding, and there's a lot of money out there. There was the CARES Act. You know, I'm more of a wastewater person. I'm not a FEMA funding person. But one thing that we would like to do is to discuss this with FEMA, you know, and to discuss FEMA Public Assistance Category B support for public health monitoring and life safety. And as part of the common operating picture, or the COP as they say it. So what we're going to be doing is through the Bergen County study, we're going to apply for funding for reimbursement for the dollars that are being spent. The utility is spending some of the money. They're doing samples. They're giving us their crew to pop manholes to be out in the system, and so this is one of the next steps in that demonstration is to put this in for funding reimbursement. So in summary, and I guess what the next steps are, you know, a coordinated and connected nationwide program. One of the things that I wanted to emphasize is that the time is now. We're in a period where, as we said, the base level in most places is steady. We're seeing some upticks in some states. The warning is that there could be, and we hope not, a resurgence in the fall. And you know, monitoring this now during the summer will best give us the information to make informed decisions in the fall should we start seeing upticks. So we think that, you know, a nationwide program is needed. Collaboration nationwide, universities, standard protocols. So everybody is looking at this the same way, using the same testing protocols, the same sampling protocols, and then sharing the information and the lessons and the lessons learned. And you know, we can recover faster together, as we say here. Beverly, is there anything that you want to add to that?
No, I think it's a good time for discussion, maybe. Yeah.
Thanks so much, Beverly and Paul. I appreciate it. I think we have a few questions, and so I'll try to bin them together. There's two that address more or less the same thing. So it's are there quantitative ways to look at the virus to calculate the number of infections you have in a particular area, to correlate it to the number of people that are impacted?
The answer is right now, this is so new that that's being worked on. I would say not really just yet. One of the things that we're doing with the demonstration project is plotting the actual cases against the presence that we see in the wastewater. and studying what that relationship is. And, you know, can we find this, and then can we use this as a predictive tool for the number of cases? Right now, we're providing trends. There is an increase in providing that information to the policymakers. I don't know, Bev, if you want to add to that a bit.
And sorry, the question was about relating to the population impact.
Yeah, predicting the number of cases, basically.
Yeah, so there has been some information shared about the massive residual RNA virus in infected individuals, but there is a lack of confidence as to whether it's 40 or 60 or 80% of infected individuals will shed the virus at the same rate. So I think to be safe, I think monitoring, that's a piece of work that I think there are worldwide programs now going on where we're sharing data so we can get better information on this and better clarity. But I think it's better to watch trends rather than try to predict absolute numbers at this stage. And I think that's something that is continuing to emerge.
That's really helpful. Something, you know, somewhat related, are there surrogate viruses being used to validate the methods, you know, in the pilot project?
Yeah, we are looking at a number of not just other viruses, but also other chemicals that can all help to, number one, normalize it, as I talked about, so that we can make allowances for other types of impacts. I talked about the wet weather impact, the temperature impact, but one thing that we do is we're looking at things. One of the most common viruses in wastewater is also a single-stranded RNA enveloped virus, which is the rotavirus. And so we look at rotavirus and enterovirus and these other viruses where we have better knowledge of the general discharge from population. And so that's something, as I said, when we do full sequencing, we get that information, and that actually could be one pathway by which we tie it back to the number of individuals contributing to the system. And so that is one opportunity to look at that. As with regards to a surrogate virus, it's possible to use indicators, and it's also possible to test for just a yes/no presence. It doesn't always have to be quantified. One option is that when we think that we have eradicated the presence of the virus in a community, for instance, there are simple tests that perhaps the wastewater treatment facilities will hold themselves, and they would be able each day to simply say, to process a sample on site and say, no virus. And then when they get a positive hit, they can go into the more detailed monitoring and proceed with the quantifying of the mass of the virus so that they can begin to track trends. So I'm not sure that using a surrogate is necessarily the right thing to do, but using other viruses, including those such as I mentioned, to help normalize the data is very helpful, as is using the chemical tracers, because there's generally a pretty good indication in chemicals as simple as sucrose and caffeine as to the number of population contributing to a sewer system, and other antibiotics and pharmaceuticals.
Really helpful. Something near and dear to me, you know, I'm kind of on the policy front. What's the biggest barrier to this happening now? Is it cost, or is it something else?
I don't think it's cost. I think it's funding. Sorry, Paul. You go.
No, it's okay. That's okay. Yeah, I mean, it's funding. Yeah. I think also too is informing the policymakers, the health professionals, or the public health people, how they can use this, and once we give them the data, how they can read it, and bringing them up to speed, more or less, or informing them how this can be used. I think is something that is needs to happen more to get more traction to get this implemented.
Here's a question. I'm not sure that it is somewhat related to that, but is is there, and we can answer it afterwards if not, and I'll do a little bit of research as well. Is there some provisions already in the CARES Act for wastewater treatment plants that may be applicable to this? You know, maybe it's the money that's already been available to municipalities. You know, maybe it's something else. So I want to know if you guys were aware of that.
Well, we are, and this is what part of the test will be, is that, this is really a life safety issue, where I don't think the CARES Act specifically addresses wastewater treatment plants. This is my understanding, and like I said before, I'm not the expert, so we can get back with more specifics on it. But my understanding is that, as this being a life safety protection type system, that it could be.
And just in my limited knowledge of the provisions that are already there, is that in discussions with the water sector, there was a big gap in how Congress addressed water and wastewater utilities in the first tranche of the CARES Act, and so there's a sense, when they went back to fix the PPP program, were they going to address that? I don't think that they did, but I know that there's been some discussion specifically on that. And we can, again, this is where I think that kind of the public policy debate and where the chamber will be happy to work with you on that. There's lots of questions here about some of the kind of tactical issues related to this, and I'll just throw a few of these and see which ones you that might be interesting to answer. So, one is, can you follow the progress of the Bergen County studies as it happened? Is it published data thus far, or when are you planning to publish that?
We don't have it put on an electronic dashboard at the moment. We have been just sharing information.
As you said, we've been sharing information
with the municipal agency, and they, of course, have been sharing it with their.
Sharing it with the county, with the client. As I said, we're just getting the phase 1 data back now, and we're plotting that against the actual cases. The client that we're working with covers 60% of the county, and the county executive now wants to expand it to the full county. So, it's that, and then they want to make that part of their public information.
Perfect. And these are somewhat fall from that. Does the tool currently only identify what we're already looking for, or there's a way to detect if something new that we might be looking for or monitor with the novel coronavirus?
Yeah.
So the methodology that we've opted to use is more comprehensive, and mostly because this is the time to learn the most so that we bring the greatest value. So the tool that we use is monitoring for a full range of viruses, bacteria, basically all RNA, all DNA in the wastewater, plus a full range of chemicals. So that, and it's non-targeted chemical monitoring, so that, for instance, later, if we get we are asked if such and such chemical was present, it's possible to go back and track for that. So the purpose of doing that, of course, is, as we said, to make sure that we track mutations in this virus, and it can be useful even to see the movement of the strains of the virus. One example might be if you're next to a long-haul international airport and beginning to see people fly into the area, and all of a sudden there's a whole new strain of virus coming into a community. These are the types of things that I think it's probably prudent to be aware of, and that's why we were doing a very comprehensive analysis in this particular study.
Are there standard operating procedures that, relative to either lab or standpoint protocols, that when the pilot is done, that you'll be sharing to kind of push this out into the public domain?
Yeah, and I think we're refining those as we go along, and we talk a lot with others, both internationally, as I said, the UK and Australia and the US. We had a joint call on protocols recently, but even within the United States here, sharing and discussing this with other entities to make sure that as quickly as possible, we are trying to make sure that what we learn about the sensitivity in the protocols is being shared with other communities. But we see great value, frankly, in having a nationwide standard. And there are nuances to how one collects a sample, how one processes the sample, even though the detailed protocols are defined by CDC for the actual testing, qPCR testing. All the steps that one takes up until that point impact the sample. And then there are really important factors about normalizing and quality control of the results that we think are not being discussed enough.
Well, that seems to me that that's a significant public policy challenge. I guess, what do you see the time frame in getting a standard or those SOPs in place so you could have a standardized approach? I mean, if we're looking at the summer to test this out, to implement in the fall, is that realistic, or do you think that it's going to take a little bit more time?
I think we've actually completed that protocol development now. We've been looking at it multiple ways in this particular demonstration. And I think those protocols are established now as far as we are concerned, that we've been discussing that. So I think the protocols are signed, and I think now it's a matter of sharing those, really. Paul, do you think?
Yeah, no, just that the WRF study is going on in the round robin of these protocols, so they can put their stamp on it, and that's the Water Research Federation. So
perfect. No, yeah, that's really helpful. Do you think that there's a question on individual consent? Is there some sense that you'll need individual consent to do this?
Well, this is anonymous data.
Sure,
so
sure.
We're not, so we're not testing individuals. We're not, that gets into the individual testing, and then when you get into contact tracing, where those issues start to pop up. So for this, I would say no.
Well, here's something somewhat related to that. Could you scale this to the individual level? Looking at feces or peeing in a cup, is that something that you guys have talked about?
We've talked about it, and unfortunately, I don't think it's there yet. This was, there are, we talked about litmus test type testing, and I think it's not quite there yet for the individual level, unfortunately, using this technique. I think probably the existing individual testing techniques are better for that. However, small communities, nursing homes, small groups, universities, schools, I think this could be applied at that level, which again brings you back to more of an anonymous situation, and again gives you that opportunity to say, all clear, oh, we're seeing something, now let's deploy individual testing to see who the infected individual is so we can treat accordingly.
Oh, perfect. Is there need to retrofit wastewater treatment plants or to install sampling stations? What are other resources that are needed to put this system in place?
Yeah, most treatment plants sample. They have their composite samples. In some of the smaller facilities, you may have to put a composite sampler in, but that's just a tabletop type. It's very easy. So there's no real retrofit needed. In some of these other areas, we can take what's called a grab sample also, which is pretty much just taking a bottle full at a given time. So no real changes. What you do need to know, though, is how the system works, how it's connected, where the nodes are. So that's why I was showing with Bergen County, where these metering chambers are. That's where they bill people from. But these are points that break the system up, very small, that you can take tests out of and get a certain neighborhood or a certain group of homes. So that's what's really needed is the knowledge, the GIS mapping of it, so you can have that type of info, so you can implement this on a system-wide basis.
And we don't even, many wastewater treatment plants don't even take a composite. We did a comparison on the grabs to composites even at the influent, and they're not that different. Actually, the data was surprisingly good. So even plants that do not take a composite, it's not essential to do that. So we're surprised at how good the correlation was.
That's very helpful. Over how many months does it take to establish a baseline? Is that part of your thinking in doing this?
Yeah, I would say we've now been monitoring for over 5 weeks, is it, Paul? And I think, yeah, I feel like because we did it not just once a week. This is the frequency at the beginning. We felt was quite important to get that established baseline. So we were monitoring 6 days a week, and now we feel like we understand the daily variability, which is rather minor, and so we have that all refined. Now I think we can go back to monitoring once or twice or 3 times a week, depending.
Right.
So the baseline, I think, early on is a good thing to do. Have a good solid sense of the day-to-day variability. I think the variability in a large system might be less than in a smaller system, where we have pump stations continuously triggering in a large system, so that there's a relative amount of continuity in the influent wastewater. Smaller systems, one might see greater variability. It's good to know that right at the beginning to set your baseline. Sure,
and related to that, so two kind of connected questions, and we're running out of time here, so I want to be sensitive to that. So what effect does distance have on the collection of samples? How close do you have to be to the source? I'm assuming that it doesn't, but I could be wrong in that assumption. And then how many samples do you need to take in order to understand what's happening?
So the distance of the source of the wastewater to the treatment plant. So that the thing that we need to be aware of there is not so much the distance and more the detention time in the sewer, because the longer it's sitting in a warm system, the more decay that will occur, and so it requires greater sensitivity than in the analysis. So that's just something that, again, if it's the same system, it's the trends. Watch the trends rather than absolute numbers, perhaps, although we would like to correct for that. The second question was, the number of samples.
How many samples?
Again, I think at the beginning, it's probably good. Take 1 sample a day is generally good, and it depends on whether you have that baseline and you have a good baseline to work from. But maybe as we go through the summer, once or twice a week would be sufficient until one sees an upward trend, and then, might choose to be more frequent. But population doesn't change that much. It's really more about getting ahead of it. So as they come into the autumn, it might be wise to go to 3 samples a week at a plant, for instance, every other day.
And finally, there's a couple of questions on the risk to wastewater operators or personnel that are in place. I guess there's a study in Delaware, a monitoring wastewater study in Delaware. I don't know if you guys are familiar with that. And then the relationship between migration in the wastewater to migration in the air. And so wondering if certainly because there's that element in wastewater, does that impact safety for those workers?
Paul, do you want to tackle that?
Well, yeah, I mean, what we're seeing is that there are studies. One study that we just read that just came out said that it is not infective. There are other studies that question that. So the real answer right now is that it's being studied. Is it in the aerosols from the waste from the aeration tanks? Right now there is really no hard evidence either way in the studies that we're seeing, and it's something that we want to look at as a community. Bev, if you want to piggyback on that.
I mean, the general, there's no evidence of anyone being infected from wastewater. That is an absolute, there has been no evidence to date. And the basis of that is that the virus is very quickly disrupted, frankly, with the acids and the pH in the intestinal system. And so that was the basis upon which any testing that was performed in one of these recent studies indicated that once the envelope around the virus is broken, that virus is no longer viable, and they had found no indication of any viruses in stool that were still infective, and even when they tried to culture them, there was no infectivity. That does not mean it's an absolute. I know CDC is continuing their research on this, but to date there's been no evidence of wastewater treatment plant workers being more infected than others. But that does not mean not to be very careful and wear the personal gear and be safe. And that's, as Paul said, we plan to continue to support that research as well.
Well, thanks so much, Beverly and Paul. I sure do appreciate it. Thank you for your responsiveness and this great presentation. A lot to think about. Now back to you, Trina, to close it out.
Thank you.
This has been really fascinating, and I know I certainly learned quite a lot. So Beverly, Paul, and Chuck, thank you so much for sharing your expertise with us today. Thanks to our audience for participating. In closing, please take care, stay well, and enjoy the rest of your day. Thank you.
Thank you.
Thank you.